very common problem which is seen in 1 to 5 years of age child in the summer season, and this is most commonly seen in this season. So, by definition, acute gastroenteritis is an inflammation of stomach and intestines, mostly caused by bacteria or virus. Usually, diarrheal diseases of rapid onset with or without accompanying symptoms or signs such as nausea, vomiting, fever, and abdominal pain. Diarrhea, frequent passage of unformed liquid stools, that is more than three or more stool, watery stools per day is known as diarrhea, or increase in fluidity, volume, and frequency of stools. Dysentery is blood or mucus in stools is known as dysentery. The types of diarrhea in children less than 5 years, it is short in duration, less than 2 weeks is seen. That is called acute diarrhea, often caused by upper respiratory tract or lower respiratory tract infection with antibiotic or laxative therapy. Subside This usually subsides without treatment of dehydration. It may be also called as acute infection of diarrhea, infectious diarrhea. Usually, acute diarrhea is typically self-limiting and resolves quickly with no not lasting for more days with sequelae. The second type of diarrhea is chronic diarrhea that is lasting for more than 2 weeks but resolving within 1 month. Within a month, it is known as persistent diarrhea. Chronic diarrhea can be a result of disease process, medication, or genetic abnormalities. Then the third type of diarrhea, which is intractable diarrhea of infancy. It is the syndrome which is occurred in infancy, occurs for few weeks, few months of life, persistent longer than 2 weeks with no pathogen, and it is referred as refractory to treatment. So, to describe acute diarrhea, presence of three or more loose stools or watery stools within 24 hours. Dysentery means bloody diarrhea, visible blood and mucus is present. Persistent diarrhea, that is, it is lasting for more than 14 days. So the different bacteria and viruses which causes diarrhea are bacteria. There's a huge list, which usually in first 5 years, usually it is Vibrio cholera, E. coli, uh, Staphylococcus aureus, and Salmonella, Shigella. These are the species which more bacterial organism which affects the gut. Viral are usually in all pediatric age group for at least first 2 years of life. Rotavirus, norovirus, adenovirus are most commonly affected. And the non-infectious causes of diarrhea are errors in feeding, wrong formula, wrong dilution, food intolerance, inflammation of the gut, sciatic diseases, gut surgery, mucoviscosis, and infection outside the digestive system. Most common pathogens in pediatric age group are Salmonella, Shigella, Escherichia coli, E. coli, and Campylobacter. Causes of these all bacterial causes up to 10 to 15% of diarrheal illness in mostly underdeveloped nations. So bacterial gastroenteritis, that is blood, there may be the signs and symptoms may be plus or minus bloody stools may be seen. Child appears symptomatically ill. Greater degree of dehydration is seen. Abdominal pain is most common symptom which child arises. Rising of inflammatory markers, stool cultures which show leukocyte more than 5, and fever develops in most of the cases. Up to 70% of children get fever. Bacteremia is seen in 1 to 5% of child, and the most common virus which viral fever which causes diarrhea is the rotavirus, and it is very important to detect to control rotavirus deaths also in child. Usually, it is seen from first year 2 3 months to 2 years of age. Leading This is the leading cause of severe and dehydration seen in children. One third of all diarrhea admitted child in 5 lakhs deaths are seen due to rotavirus. Neonatal infections are common occurrence but are often asymptomatic. The incidence of illness is seen from 4 months to 24 months of age. This is fecal-oral transmission. Sudden onset is seen. Watery diarrhea with or without vomitings are seen. And usually these are self-limiting, may take from 1 day to 6 days and up to 1 week usually. And it is seasonally seen, uh, like in tropical climates when summer is peak or and in winters. The whatever reason might be due to which is causing diarrhea, the thing the practitioner or the household mothers and mostly mothers and at home we should see clinical evaluation is most important in this. Clinical evaluation, which has assessing the severity of the illness and need of rehydration, identifying likely cause of the likely cause of the diarrhea. This is usually identifying the organism or pathology is usually can be noted by having a detailed history or clinical findings. So usually, uh, clinical history, diarrhea may be caused due to foodborne, waterborne, when seafood, when child is exposed to some poultry, eggs, peas, or any antibiotic therapy. And there is a list of organisms which get affect which is seen. Usually, salmonella are foodborne diseases, and waterborne are Giardia, Vibrio, cholera, and eggs are Salmonella, Shigella. These organisms are affected, are gained due to these organisms. So, from the history wise, usually, if it is Staphylococcus aureus or Staphylococcus aureus, the onset is within 6 hours of the the start of diarrhea. It is usually gut get infected within 6 to 24 hours in few organisms like Salmonella, Shigella, and viral thing. It is after 16 to 72 hours. Within 3 days, it is usually seen. And in evaluation, the main thing which I told was history, onset, the frequency, the quantity of diarrhea should be noted. Whether it is having bilious, blood stools, or mucus stools should be known. Whether it is associated with any vomiting is seen or not should be noted. Physical examination, baby's weight should be noted. Is the baby having temperature? How is the respiratory rate, BP, pulse should be noted. Assessment of dehydration, general appearance and alertness of the baby should be noted. BP, pulse of the baby should be seen. Postural hypotension is there or not. Mucous membranes and tears. Shrunken eyes. Skin turgor should be in home. We can only see few physical findings like shrunken eyes, skin turgor, capillary refill time should be can be seen, and the anterior fontanelle, shrunken fontanelle. Usually fontanelle is it is usually seen from up to 18 months of child. Usually the middle dip of the skull is called anterior fontanelle. Whether it is full or it is deprived, you should be noted. Approach to pediatric dehydration. As I told, initial resuscitation, determination of the how much percent of dehydration should be seen, define the type of dehydration should be known, and determining the type and rate of rehydration fluid which has to be given should be seen. The fourth point which I told is the rehydration fluids and therapy. Usually it is done in hospital, and that too in severe dehydration. With the type of dehydration, it is classified into three: mild, moderate, severe. Usually, mild it is 4 to 6% child is affected. Moderate dehydration is seen up to 6 to 10%. Severe dehydration it is seen in 10 to 15% of children. So the assessment scale of dehydration uh, should be noted in this form. In general appearance, pulse, respiratory rate, fontanelle, eyes, tears, shrunken, skin elasticity. Usually, if if general appearance, baby in mild cases are thirsty, restless, alert. In moderate, they are thirsty, drowsy, lethargic. In severe, it is limp, drowsy, severe sweating, cyanotic peripheries of hands and legs are seen. Radial pulses are normal in strength, rapid and weak in moderate, and severe, rapid, very low pulses seen. Respiration, it is normal in mild, deep in moderate, deep and rapid in severe. So, in general, at home, if baby is breathing fast breathing or something, that we should, and baby is totally dehydrated, we should think of it as a severe dehydration. And as I told, anterior and fontanella, we should check with our hands on the baby whether it is full or shrunken inside or very low. Pulse rate and all is usually seen in hospital. Skin elasticity, it in mild cases, the skin turgor will be normal, and in moderate, pinch reaction is slow in moderate dehydration. In severe dehydration, pinch reaction is very slow, and skin turgor is also very weak, very soft, where like old man appearance it is seen. Usually, kids' skin should be healthy, and due to water losses are not there, it should be normal. And due to wasting of water is seen, the skin like old man appearance it is there. Eyes, in mild cases it is normal. In moderate it is shrunken. It is grossly shrunken in severe. Tears are present in mild cases, and they are absent in severe to moderate. So the major three classes of dehydrations are isonatremic, hypernatremic, and hyponatremic. So volume depletion, contraction of IV fluid plasma pool is seen. Isonatremic, usually most common dehydration in children, where volume and sodium are proportionately less in these babies. And that can be given through oral fluids and it can be corrected. And hyponatremic means the sodium levels are too low with the volume depletion is also seen. And hypernatremic, it is only the water is getting lost and sodium values are elevated in these cases. That is called free water loss. So usually for every dehydration, moderate to severe dehydration babies, we need to have an serum electrolyte reports also. So the laboratory thing for mild cases is not required. For moderate to severe, it is always good to have first line uh, first line labs in our hands, like CBP, inflammatory test, infection test, stool analysis, stool culture should be sent, and serum electrolytes should be seen. Why? Because the corrections of fluids and all depends upon the electrolytes which are seen in the body. So these are all the hospital thing which we are doing. Usually, what is the preventive steps you have to take at home? It is very simple, but in children, it is very tricky also sometimes. So few things are safe water, safe sanitation, hygiene, food, well proper cooked food, uh, and weaning foods should be seen. And any micronutrient supplementation deficient are there or not also be seen. Like safe water, baby should be given boiled water. It is always good to give boiled water after in the summer. Boil the water. After cooling, you can give the child. Why? Because in summer, the wells, the water bodies shrunk down, and contamination of water is seen more, through which more bacterial or viral fevers reappear. Sanitation, houseflies should be are most common transmitters of infection to the child. That should be noted. Hygiene, just safe hand washing should be seen. Seafood, proper cooking should be seen. Cooking should be done. Exclusive breastfeeding for infants should be encouraged always. So treatment, usually this is for usually it is divided as oral ORS rehydration should be seen. In oral rehydration therapy, usually it is within 3 to 4 hours of treatment. When dehydration is corrected, age appropriate fluid should be told to be given. Continue breastfeeding. Regular formula feeding should be given. It, in these cases, uh, unnecessary blood laboratory tests is not required. Administration of ORS fluid is only the treatment. So, why is this ORS therapy most important in this child? Usually, it is appropriate for mild to moderate dehydration. It is the treatment and it is the lifeline for all children. It is safer, less in cost, and administered in various clinical settings also can be done. Fluid replacement should be given within 3 to 4 hours. If it is in mild dehydration, it is 50 ml per kg you should be giving. So if you think a baby is 10 kg, you need to give 500 ml, means 500 ml of bottle to be given to the child. If it is moderate, it should be given in 100 ml per kg. And for each vomiting or diarrhea, 10 ml per kg, you need to rehydrate the child. In that way, you don't lose electrolytes and liquid depletion also be correct. Minimal dehydration with no no signs of dehydration. Rehydration therapy is not required. Replacement of fluid is only required. Like as I told, for each diarrhea or each vomiting, 10 ml per kg of ORS water should be given. If it is below 10 kg, 6 to 20 ml per ORS should be given. And nutrition wise, same you have to continue as a routine whatever you're giving, and there is no restriction. And if it is mild to moderate dehydration, that rehydration therapy should be given for first 3 to 4 hours, and ORS water from 50 to 100 ml per kg of body weight should be given. Replacement of losses below 10 kg body weight, 60 to 20 ml ORS in each diarrheal stool or vomiting episode should be given. And nutrition wise, breastfeeding and normal diet should be continued and initiated dehydration. Uh, the contraindication of oral rehydration therapy are if the baby is severely dehydrated or any surgical cases like ileus or intestinal obstruction, unable to tolerate, signs of shock, decreased level of consciousness, unclear diagnosis, and psychological situation, we should not give ORS therapy, ORT therapy. And in severe dehydration, usually we should, the first thing we need to do is replace the lost fluids from the body through IV fluids. That is, rehydrate with ringer lactate solution, 100 ml per kg IV within 4 to 6 hours. Then you have to slowly, after everything is normal, ORS should be started. And replacement of losses, same as 60 to 120 ml per ORS for each stool or each vomiting episode. So, and antibiotics usually not much required in gastroenteritis. Usually, mostly we see is viral thing, and very short acting. If at all, as I told before, in stool culture or anything suggestive pathogens are seen, usually in cholera, usually the treatment of choice is tetracyclines or doxycycline, or azithromycin or ciprofloxacin should be given. If it is sigilla components, we should start ciprofloxacin or floxacin, or ceftriaxone should be given. And if it is parasitic amoebiasis like that, metronidazole should be started. Yes. And in any case of gastritis, the most useful thing which baby can heal the intestines and stomach is through probiotics. Usually, there are several probiotics you all know, like Saccharomyces boulardii and lactobacillus components which are there. These should be given for 3 to 5 days usually. That will heal the baby intestines and all. And it is very beneficiary in intestinal flora and gut repair. And zinc supplements should be always suggested for all the gastroenteritis baby, as zinc uh, is useful in a very healing process and all. And it should be given in 20 mg per kg for 14 days. Yes, thank you. And as I told, the preventive steps are hygiene, proper hand wash, proper cooked food, contamination. If you can prevent this from children, usually we see low G. Thank you.